Vaccinations. My name is Micah Grant-Huntrup, and I am one of the Public Health Project Coordinators here at NCUIH. Also joining us today is my colleague Tiffany Stark, who is one of the Public Health Program Managers here. Tiffany and I will be your hosts for this event. We would like to thank you for volunteering your time today to participate in today's discussion. We at NCUIH appreciate your willingness to share your personal experiences with vaccines for COVID-19 and beyond. We do understand that this can be a sensitive topic, specifically during a pandemic. This is a safe place, and feel free to share as much as you feel comfortable sharing. There are no right or wrong answers, and we know everyone is in a different place with capacity and vaccine progress, so this is just a chance for us all to learn from each other. Next slide, please. We want to welcome you again. We're very pleased that you could join us. Your answers today are very important and will allow us to further understand your needs around adult vaccinations, specifically COVID-19, flu, and RSV, and how NCUIH can better assist with any barriers or roadblocks as well. If you do have any IT difficulty during today's call, please chat directly to Comms and Events, and Carmen can assist you. Finally, if you could please enter your name, UIO, or external organization and any tribal affiliations into the chat box so we can get to know each other better. Next slide, please. Before we begin, we would like to review a few quick housekeeping items. Please, if you have video capability, enable your camera, as this helps us create a more interactive environment. Also, please note that your microphones are muted, but you will have an opportunity to ask questions. You can raise hand at the bottom if you'd like to be called on, or just unmute if there's silence and pop in. Our chat box is being monitored as well by both myself and Tiffany, so feel free to drop any questions or comments throughout the presentation, and we will address them at the designated time. Next slide, please. Just a note that this session is being recorded for educational and quality improvement purposes. Your answers will not be published, and the information you provide will be used to further inform our research and programs. This content was funded in part by a cooperative agreement with the Centers for Disease Control, so we do want to acknowledge and thank them for their support of this project. So to begin, we would like to provide a brief background on NCUIH for those who may not know. Our organization is a national nonprofit devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaskan Natives living in urban areas. We represent the 41 Title V UIOs under IHS in the Indian Healthcare Improvement Act. We strive to improve the health of over 70% of the AIAN population that lives in urban areas, supported by quality, accessible healthcare centers. We do invite you to share your feedback with us after this community of learning event by our post-event evaluation survey, and we will drop that link in the chat. Your comments are always appreciated and help us improve our technical assistance in ways that we can help make our programs work for you. Quickly, we'll go over the agenda. So we've done our welcome and our housekeeping items. We will start with a presentation from Dr. Manisha Jutani of the Connecticut Department of Public Health, then hear from Elise Balzer from the CDC's and Indian Health Service, and conclude with Amy Pisani from Vaccinate Your Families. Following the presentation, we will have an open floor for any questions or comments, and then conclude the presentation. So, Dr. Jutani is the Commissioner of the Connecticut Department of Public Health. She is the first Indian American to serve as a commissioner in the state of Connecticut. She served as Director of the Infectious Diseases Fellowship Program from 2012 to 2021. Dr. Jutani received her BA from the University of Pennsylvania and MD from Cornell University Medical College, completed internal medicine residency training at New York Presbyterian Hospital / Weill Cornell campus, and served as chief resident at Memorial Sloan Kettering Cancer Center. She came to Connecticut in 2002 as an infectious diseases fellow at the Yale School of Medicine. So please put your favorite drink emoji into the chat to welcome Dr. Jutani.
Thank you very much for that introduction. And just to be clear, and thank you for all the emojis. I am currently serving as the commissioner of the Connecticut Department of Public Health and speak in that capacity, specifically on these seasonal vaccines that we're going to talk about today. We can go to the next slide.
All right, I'm working on it.
Okay, thanks.
Oh, there we go.
Okay, great. So I thought what we would do is first just level set where we are with each of these diseases before I go into the vaccination recommendations for each of the 3 vaccines that we're going to talk about today: COVID, influenza, and RSV. And so when we look at the epidemic curve, or the epidemiologic curve of hospitalizations from COVID-19 since the beginning of the pandemic and going now until October of 2023, you can see that hospitalizations obviously reached those huge peaks back in the Delta wave, which is that first peak that we see. Actually, that was the Alpha variant wave, followed by the Delta wave, and then the Omicron wave, which is in that late December to January of 2021, which was the highest number of hospitalizations we ever had. And when I came into my role as commissioner in the health department. And we're obviously in a very different place right now as we look at the number of hospitalizations, where we are on the far right of this graph in October and November of 2023. But that doesn't change the fact that the immunity that we have from COVID vaccines and from natural infection does wane with time. And we also know that the burden of COVID is most significant in our oldest age groups, particularly those 55 and older, and with those with underlying medical conditions. So although we are much lower than we were at previous points during this pandemic, we still have hundreds and hundreds of hospitalizations every week. To give you an example, because I was discussing this in Connecticut just today, we just reported our first death from flu. We had 2 deaths from RSV. And in the month of October, that's for this season, starting October 1st. And for the month of October alone, we've had 67 deaths from COVID-19. So COVID-19 still remains the most morbid respiratory viral infection that we have circulating in our community. And racial and ethnic minority groups have been disproportionately affected by COVID-19, with total burden of this disease of over 1 million deaths in all populations since 2020. Next slide. So just to revise and remind everybody where we are right now in terms of COVID-19 vaccine recommendations. For people age 5 years old and older without any immunocompromise, the recommendation is for 1 dose of the COVID-19 vaccine that is new this season for the 23-24 season, regardless of prior vaccination history. So what does that really trying to get at? If we have anybody who's been unvaccinated in the past, all they need to do to be considered up to date with COVID vaccines is get 1 shot, the newest shot, regardless of when the last shot essentially was that somebody may have received. This recommendation now is that for this season, everybody 6 months and older should get 1 dose of the COVID-19 vaccine. And particularly, why do I say for those who are 5 and older, there was more complicated recommendations in the past about, if the number of vaccine shots that a new child coming into the system would need to get. But if a 5-year-old has not been vaccinated before, they can just get 1 shot. And this dose is recommended at least 2 months after the last COVID-19 vaccine dose that somebody may have received. So if for some reason they got a shot earlier this summer, they would still be eligible for this new vaccine this season. Next slide. So for those who are 6 months old and older, I think and those who are moderately or severely immunocompromised, the only difference is that for 6 months to 4 years, the recommendation is to get that initial COVID-19 vaccine series. This is also true for moderately or severely immunocompromised. That really means either 2 or 3 doses, depending on which shot and which age group, and then can get the additional dose of the newest vaccine that's come to market more recently. So for many people that who may have gotten the initial series of vaccines for COVID, all they need to do is get this newest shot. If this is a person who's never been immunized before, or a child who maybe was never immunized before, under the age of 5, then they should get the initial series of shots and then get the one that we're talking about right now. Next slide. Okay, so we're going to move forward now to flu. And what can we say about flu overall? So the burden of flu, we have 27 to 54 million flu illnesses in this last season that we had, with 12 to 26 million, 26 million flu medical visits, resulting in 300 to 650,000 flu hospitalizations and 19 to 58,000 flu deaths. And so this is, ranges that we have from the CDC. Overall, the burden of flu really varies year to year, and so we just don't know what's going to happen in this upcoming season. Next slide. So again, the recommendation here is pretty simple, which is that for all persons aged 6 months and older who do not have a contraindication are recommended to receive a flu vaccine. And for those who are 65 and older, there is a recommendation that they can get one of the higher dose flu vaccines, or what's called the adjuvanted flu vaccines. This includes 3 by the brand names of Fluzone, Flublok, and Fluad. Flublok has had some back ordering, but the bottom line is for all others who are 6 months and older, a regular flu shot is fine. For an older adult, 65 and older, the higher dose flu vaccine is what is recommended. And this can also be administered with the COVID vaccine. So that is definitely what I would recommend to people, is to get both. If they're not going to be able to stagger them, there's certainly no contraindication getting both at the same time. Next slide. And so for the third vaccine that I wanted to talk about, this is for the virus called RSV. So, at this time of year, there are actually multiple respiratory viruses that circulate in our community, but the 3 we focus on are flu, COVID, and RSV, because these are the three that we have immunizations for. So RSV is recommended for children under the age of 5, but specifically really for our infants, our smallest infants. And why is that? It's because the burden of RSV is highest in our youngest of young and those who are 60 and older. So if we just take a look at the burden of disease for children under the age of 5, they have 1.5 million outpatient visits, which can result in 520,000 emergency department visits, up to 58 to 80,000 hospitalizations, and 1 to 300 deaths per year. Last year, because we were coming out of COVID and the children at that time had not been exposed to RSV in the way they normally would have been, we saw an early surge in RSV starting in September and October, and then settling down. What we're seeing this year is that RSV seems to be following more of a typical pattern in terms of its circulation in our community, which in some ways can make it a little bit more predictable to ways we have experienced it in the past. So that's the burden of disease in our youngest of young. The next place we see burden of disease is in our older adults, those who are 65 and older. And you can see the burden of RSV versus flu, it is definitely less. So 6,000 to 10,000 deaths per year versus the 16 to 43,000 deaths per year for flu. And COVID is the most out of all 3. But that having been said, if you can go to the next slide, I'd like to review at least what the vaccine recommendations are. So there are 3 groups that RSV is recommended in, but for our older age group, it's really recommended that a person speak with their provider about whether the RSV vaccine is the right vaccine for them. And why is this? It's because for people 60 and older, we certainly see that is where we see the burden of disease. But as you get older and as you have more immunocompromising conditions, the more likely RSV could have more of a significant impact on you. And so how big of that impact it might be, that is something that speaking with a provider can help with. For babies who are newborns, this is the time we want to try to capture as many babies as possible. And there are two ways to do that. A woman who is pregnant between 32 and 36 weeks, that is the time it is recommended to get a shot. And it's actually the same shot that the older adults get in order to protect your baby from the moment they are born. And so for those who are 32 to 36 weeks pregnant, it's recommended to get that shot. If you don't do that, when a baby is born, there is a monoclonal antibody called nirsevimab, which is an immune therapy. So it's not a vaccine, but it is an immune therapy that also will protect these babies right after birth. And so the goal is to get as many of these children protected, either when they are still in the hospital or when they go to their first pediatrician's appointment. And that is what's happening in many communities. So this is what's recommended for our older age groups and our youngest to be able to protect against RSV. Next slide. So I just wanted to share, these are some different links to different resources that can certainly answer questions and provide more information about access and where people can go to get these therapeutics. And that is the end of my presentation. Thank you.
Thank you so much for that presentation, Dr. Tutani. We really appreciate it. Next up, we will hear from Elise Balzer. Ms. Balzer has been a public health advisor with the Centers for Disease Control and Prevention since 2010, where she has worked in the field as an assignee to state and local immunization programs. She took a short break away from CDC, where she was the director of the state of Illinois immunization through Ever Thrive, Illinois, from 2015 to 2016. Ms. Balzer's most recent CDC assignment started in June 2023 with the Indian Health Service National Immunization Program. In all of her CDC assignments, Ms. Balzer has consulted with dozens of clinics, tribal health clinics, and local health departments on ways to apply quality improvement sciences to vaccine uptake and increase patient trust. So if you would not mind putting in your favorite food emoji into the chat to welcome Ms. Balzer.
Thank you so much for that welcome. I really appreciate it. Next slide, please. Ooh, look at those fun emojis. Chocolate bar, I like that one. Thank you. Next slide, please. So let's jump right in. What are we doing here today? So my goal over the next few minutes is to go ahead and talk a little bit more in detail about some of the ways that respiratory diseases can impact those who have health disparities. So Dr. Junta did talk a little bit about these, so I thought we could go into a little bit more detail. We're going to go ahead and discuss some of the tools available now to prevent or reduce respiratory diseases. And I do want to take a little bit of time to discuss some of the strategies to implement tools, to implement these vaccine recommendations in a clinic. And really, these tools that I'm going to talk about today are evidence-based strategies that have worked well in other clinics. And I think about these strategies kind of like a buffet, so you can kind of pick and choose what will work well for you in your clinic and your communities, because you are the experts and you know your clinics and patients the best and know what will work well for them. Next slide, please. So I thought we could go ahead and start off with a poll. So if you can enter into the chat, please, what you think the answer is. So what is the #1 cause of death for American Indians and Alaskan Natives? Is it accidents, heart disease, respiratory diseases, or cancers? Yeah, I'm seeing a mix of things. Can we go to the next slide, please? It is, in fact, respiratory diseases. And if you can go to the next slide, please. And specifically COVID-19. And so I should say the caveat with this, sorry. The caveat with this is that these statistics that I'm sharing with you today are from 2021. So if we think back to Dr. Junta's first few slides where she was sharing the epidemiology of COVID-19, hopefully over the next few years, we'll start to see that reducing. But for right now, as of the most recent data that we have, COVID-19 is the most common cause of death for American Indians and Alaskan Natives. Next slide, please. Before we do start talking about the health disparities, I do want to acknowledge that we know that because of racism, both structural and interpersonal, that American Indians and Alaskan Natives have higher rates of health risk factors that make infection with a respiratory virus difficult for a person's immune system to fight. Next slide, please. So, for example, compared to other racial and ethnic groups, American Indian and Alaska Native people have higher rates of HIV infection, the highest hepatitis C-related deaths, the highest rates of cardiovascular disease, coronary heart disease, and stroke. And guess which of these risk factors makes it even more difficult for a person's immune system to fight an infection with RSV, flu, or COVID-19? Next slide, please. As you probably guessed, it's every single one of these. And I know for many of you, you know the names and the faces of the people who make up these numbers and these statistics. My goal in sharing this information is to really set the table around the conversation for why vaccination is important for people with high risk factors to get their flu, RSV, and COVID-19 vaccines, and to think about ways that their family members and community members around them can protect them as well. Next slide, please. So I do want to also acknowledge that there are other risk factors that do contribute to getting a respiratory disease virus. So folks who are immunocompromised, some people with certain disabilities, certain underlying health conditions such as chronic lung disease, heart disease, or obesity, overcrowding housing, children younger than 5 years old, older adults, pregnant people, and those living in long-term care facilities. And again, I do want to thank Dr. Junta for her presentation and acknowledging some of these risk factors already. Next slide, please. And so this season, we are so fortunate that there are so many ways than ever to protect our health, thinking of COVID-19, flu, and RSV. So we have vaccines that protect, vaccines or antibodies that are available to protect against flu, COVID-19, and RSV. We have widely available treatments. We have rapid antigen tests and everyday actions. So I think about these tools as kind of a circle where each of these tools plays its own important role in preventing or reducing people's risk factors for getting a respiratory disease virus. And each of them is important in their own way. But because we're here to talk about vaccines, we'll go ahead and do that. Next slide, please. So as I promised, I'm going to start talking about some of the strategies that you and your clinic can consider for increasing vaccine uptake. Before I do, I want to think through that all of the strategies that I'm going to share really fit under the umbrella of patient trust. And trust is one of our core values in public health and in healthcare. And what I mean by trust, this is my definition, but what I mean by trust is it's the feeling that a patient has about the staff person giving the vaccine, the vaccine product that they're receiving, and the place or the system where they're receiving vaccines. So you may have also heard this concept called vaccine confidence. And vaccine confidence is a spectrum. So we have some people on the, I guess it'd be the left-hand side of the spectrum that are trustful of vaccines and have high vaccine confidence, where there are other people on the right side of the spectrum that have very low vaccine confidence or low vaccine trust. It's the people in the middle where we want to spend most of our time and resources. So in marketing, this is called the movable middle. So as you're thinking about, implementing vaccine programs, think about ways that your programs can influence the movable middle. And over the next few slides, we'll come up with a few examples and strategies for how you want to do that. Next slide, please. So I'm going to talk about 4 strategies. The first strategy that I have down is about leveraging your state's immunization information system. So I just want to say, I know very much firsthand this is complicated. It is complicated to connect to state IISs. I will also say it is the best way that we have in 2023 to ensure that patient vaccine histories are complete, to avoid over or under vaccination. And IISs also have other resources that many EHRs do not have. So for example, many IISs can generate lists of patients that are missing or behind in vaccines. And they can also produce coverage rates reports so you can track your vaccine program's process. I'd also just share a personal story. I was actually talking to a nurse a few weeks ago who shared with me that she spends almost 2 hours on every single patient's record, tracking down where the patient's vaccine histories, tracking down the patient's vaccine histories. And it just breaks my heart to hear that story, in today's world, that a public health nurse is spending that much time because their EHR system doesn't currently connect with their state's IIS. Next slide, please. So strategy number 2 is what I call creating a culture of vaccination in your clinic. So the overall goal of this strategy is that when a patient comes in, they know that vaccines are a routine part of their care. So how do you accomplish this in your clinic or organization? So the first part is to think about your staff, and the second part is to think about patient queues. So thinking about staffing, the first question you want to ask yourself is, do you have enough staff to accomplish the programs that you hope to implement? And then second of all, are the staff trained in their role in the immunization process? And when I say staff, I'm thinking about everyone from the front desk to the person who's rooming the patient, to providers in the lab. And if your clinic is co-located with a dentist, making sure that there's collaboration with the dentist as well. There are many wonderful resources for training your staff on CDC's website. And making sure that all of your staff feel involved in the immunization workflow process can create this team environment. So the second step in this strategy is creating a culture of vaccination. I think is kind of fun. So assigning someone in your clinic for things like hanging vaccine posters in the restrooms, in your waiting rooms, and making sure that culturally appropriate and up-to-date handouts are available. I believe Amy in the next presentation is going to go ahead and share some of those resources. Next slide, please. So the third strategy that I'd like to talk about is around facilitating return for vaccination. So in the era where, you might not have a certain vaccine on hand, it's really important to have strategies in place where the patient knows to come back for their vaccine. So the first way that you can do this is to go ahead and schedule that next patient visit before the patient leaves the office. So if that isn't an option for you for whatever reason, find a way to keep a running list of patients that can be called back for the vaccines, and set up a way to actually call them back. The third step is for those patients who are overdue for a vaccine, having their healthcare provider record a voice message or write a letter directly to the patient can go a really long way in making the patient feel and know that this vaccine is important. Next slide, please. And the fourth strategy that I want to share with you is honestly my personal favorite. For me, it's kind of a low cost, high impact strategy, and that is to give a strong vaccine recommendation. And so the way that this can look is by making sure that you train your clinicians and everyone on the immunization team about what a strong recommendation looks like. Next slide, please. So this does not sound like this is not, so what are we thinking about vaccines, or how, what are you thinking about the COVID-19 vaccine? It's not that. What this is but using this formula. So using because, and I strongly recommend, and the word today to create urgency, and then give their personalized why. So for example, you can say, because Susie is 5 years old, I strongly recommend that she get her yearly flu and COVID-19 vaccines today to protect her from getting sick with flu and COVID-19. And then you can just stop, because if the patient has questions, they'll go ahead and ask those questions. You want to avoid kind of going on and providing more information than the patient actually needs. And if a patient does have questions, you can then employ, other strategies like motivational interviewing, or I know the case method is really popular around vaccine communication. I recommend practicing this method either with a partner or in the mirror, because if a provider is sounding confident in their recommendation, the patient will feel confident and trust that the provider cares about them and wants the best for their health. Next slide, please. So in conclusion, I wanted to kind of go over the so what. So why are we talking about all of these things today? And why are we talking about all of these strategies? Next slide, please. Oh, next, or can you advance it? So I think the number one takeaway that we talked about at the beginning is that American Indians and Alaska Natives are dying from vaccine preventable diseases. Next slide, please. Thank you. As a healthcare leader in your organization, you can implement these workflow strategies that support vaccine uptake that work best for your staff in your community. The next one. And that vaccines are a way that communities and families can help keep each other safe. Next slide, please. I do ask that you do take at least one idea away from my talk today, and at least talk about it with another colleague or with one of your teams, and consider ways that you can implement and operationalize these vaccine recommendations. Next slide, please. And in conclusion, I'd like to go ahead and invite you to think about your family members for a moment. You or someone in your family is alive today because someone before you in your family history got a vaccine. And 10, 20, 50 years from now, our future family members will be able to look back at this moment when we began to reduce vaccine preventable respiratory diseases, and giving our future family members more time on this earth with their elders, their parents, and their children. Next slide, please. Thank you. I'll go ahead and turn it over to the next speaker.
Thank you so much, Ms. Balzer, and let's have everyone give her a warm round of applause in the chat for her presentation. Next up, we have Amy Pisani. Amy is a distinguished expert in the field of vaccine advocacy and education with a remarkable tenure dating back to 1996 when she joined Every Child by Two, now known as Vaccinate Your Family. As the Chief Executive Officer, she has played a pivotal role in shaping the trajectory of immunization accessibility in the United States. Amy's tireless dedication has made her a driving force for immunization advocacy, working tirelessly to advance the health and well-being of communities across the nation. Throughout her career, Amy has demonstrated an unwavering commitment to realizing VYF's mission, which is to safeguard individuals of all ages from vaccine-preventable diseases and bridge immunization disparities. So at this time, if everyone would please add your favorite holiday emoji into the chat to welcome Amy, and I will pass it over to her.
Thank you so much. I'm really excited to be here today. And I've already got a couple of different initiatives. At least you were saying, like, talk about one thing that you might bring forward. I have 7 things written down. So for me, you're here to talk about vaccines. For me, I think about them every day. And it's true, I have been in this space. You can go to the next slide. I have been in this space for a very long time. But Vaccinate Your Family itself, just for those of you who aren't familiar with our organization was founded 30 years ago or more, actually, by former First Lady Rosalind Carter and former First Lady of Arkansas, Mrs. Betty Bumpers. Betty was really seen as the trailblazer on vaccines. She worked in Arkansas with every single organization that had any impact on children to bring their rates up. And that was really the development of the very first immunization coalition. And so when she and Mrs. Carter worked together during the Carter administration and later, and when they created our organization, Every Child by Two, it was really all about building coalitions and trust and figuring out how do we get through and deal with all of the barriers. Well, what we knew is we're at the center of the vaccine ecosystem, but we're not at the center of the world. We need all of our partners in this together because we can't save anyone from a vaccine preventable disease if we're not working together. And so what we work on is communication and policy and community activism. And the next slide, please. And the goal is to really help to empower and inform one another, but to really learn from you. I have learned more through the pandemic than I have ever, I've really ever understood. And my cultural humility is just growing because there's more and more that I don't know. But I recognize that it's something I need to understand. And that's where we bring together the Vaccination Collaborative. So the collaborative is basically made up of many, many organizations like yours and others who became interested in vaccines because of the pandemic. And our goal is to keep all of this interest going for the vaccines across the lifespan, because everyone knows now how incredibly fortunate we are to have vaccines, but there are many policy issues that still stand in the way. We have access issues that we've been dealing with for decades. We've made really great strides in the childhood arena, but there are still areas where we have discrepancy in vaccination rates. Just today, data came out that we have a greater number of exemptions to vaccines. They're creeping up again in the states. And we also have lower vaccination rates. And what is 1%? It's somebody's child. It's a lot. So when you think that we're, 1% or 3% or how many percentage rates we're dropping in our vaccine coverage, that could impact anyone at any time. And when it comes to the adult space, my goodness, the disparities are enormous. So the collaborative works on communication and policy, and we're working on getting microgrants out so that we can help local communities do what they do best. The next slide. So we do urge folks, if they're interested in the collaborative, to come to us. It's over 250 members strong now. We meet every month. We have a listserv. The listserv is great because it's really an opportunity for anyone to share their resources or their questions. And it's something that I believe will help us to stay together through the years so that we can resolve the biggest issues that we're dealing with, because vaccines are one place, but they're only a part of the landscape of the healthcare arena. And if we don't understand where the barriers are, all of us together can't work together to resolve those barriers. Next slide. One of the reports that we put out every single year, it's called the State of the Immune Report. And so we're working on a report this year, and it is in alignment with all of our partners' priority goals. I really urge you to go to our website. You go to our vaccinateyourfamily.org, and then you go to Advocate, and then you'll find a report in there. It breaks down the issues in a very palpable way. So we talk about the burden of disease, and they may be numbers and statistics, but we talk about why that should matter to your legislator, what you can do, what are the simple changes that can be made. And so one of them is a line item for Indian Health Services. We're on board with that. We think these things are really important. So we're creating our new report, but the policies that we're focusing on are very similar to last year. So I would love it if you all would go to see that report. Next slide. So today I really do want to focus in on one of our favorite programs that we've been working on since the pandemic. And I have a couple of redundant slides in here, so I might just say pass through so we can get to the Q&A. So excuse me when I do that. But it's really talking about a program of expanding the role of promotoras and community health workers. And I know that it says community health workers, but many people are also navigating people to healthcare for vaccines that are not official community health workers. So this program is for anyone, next slide, who has questions about vaccines. We go from the very beginning, Vaccines 101. We do the past, the present, and the future. We debunk online misinformation. And then we talk to you about how to talk about vaccines. And Elise did a wonderful job explaining how the way that we present the vaccines to people, whether you're a provider or you're a family member, or you're just at a game talking to your friend, it's really difficult to navigate those conversations. And I think you will love the process that we go by, where we explain how to get through those conversations to bring someone to the end goal, right? Which is to ensure that they are protected, or that the family is protected from deadly diseases. Next slide. So the program began, we started working with our partners at Dia de la Mujer Latina, and we created the program. We had 200 community health workers trained in 2022. They spoke to more than 4,000 people about vaccines and connected 2,000 to services in just the 2 months following the training. We've gotten amazing feedback about the program. We've had 600 unique students enrolled. It's all a part of our Vaccinate Your Family University. And our goals for that, again, are all the information that you're learning today from all of our presenters. It's a lot. It's a lot. Vaccines are a huge piece of the healthcare puzzle. Where do you go to find the answers once you can't remember where exactly you heard about something? Well, come to Vaccinate Your Family University, and we will help connect you. We also, with the collaborative, feel very strongly when Elise has a new program that she wants you to know about, we want to house those, because we are the place for vaccines, but you all are working on a lot of different programs, and we want to help proliferate your helpful information. Okay, so next slide, please. So the training program itself, next slide. I kind of already went through this. So the training program is very comprehensive. It was certified in Texas. It is online. It's an 8-hour training program, but it comes in, next slide, it comes in modules. So you don't have to do it all at once. You can pop in there. I actually went in and I did the nuts and bolts of vaccines the other day. And then I went in and I learned about addressing social determinants of health and barriers to vaccination. I'm trying to learn how to better support all of the communities out there that are trying to work on vaccines. So I learn every time I come to this program. So you go to vaccinate.thinkific.com, or you go to my website and it will navigate you there. And you go into the program. Again, you can take portions of it. It's both English and Spanish. And then next page, after a person is going through the program, we created an online community. And that we felt really strongly about, because you might go through the program, but now you're in the real world and you're actually trying to navigate someone to a vaccine, whether it's in your local pharmacy or your FQHC or wherever it is you're trying to navigate someone, and you come upon, I don't want to say a barrier or a question, or someone may, they may question, I'm concerned that the COVID vaccine may affect my ability to become pregnant. You come back to our community, you ask that question, we'll help you answer it. Next slide. And then we have the quarterly meetings where we actually have community of practice meetings. And these have been a really wonderful opportunity for people to talk about what they're experiencing, how they like the training, and to help us, because we want to take these trainings and actually now personalize them for other communities. So we're moving forward in 2024. We're also, next slide, we're also giving out, that's fine, that's fine, we'll stay here. We're giving out grants right now. We just gave out our first 8 grants, and we're working on creating facilitators. We know that not everyone has broadband access. We want this to be localized. We want people to be able to facilitate the trainings in person. So we gave out these mini grants, and we're going to start the program in early January. And our goal, to tell you the honest truth, I'm all in. And so by the next 3 years, we're hoping that we can nationalize this training program. We can bring in resources. If you have resources for your community and we're doing the program in your community, that's the resources we want to give out. We don't need to give out national Vaccinate Your Family resources. So I want to thank you all for having me here. I loved the other speakers. It was great to hear all the content that's going on. And always you need updates on vaccines, because we're in the middle of flu season, RSV season, and our goal, right, and pneumococcal, is just to save people every day. So thank you for having me.
Great. Thanks so much to all of our amazing speakers. So now we'll invite everyone to come on camera if you're able to. That way we could have a more engaged open floor portion of the session. And we'll also drop in the chat our link to the survey. We definitely appreciate any feedback to help better support you in the future. But yes, now we welcome anyone to come off mute or put it in the chat. Any questions or comments that you have for any of the speakers on the vaccine updates or any of the resources that they had talked about.
Hello. Hi, I do have a question, in particular with the RSV vaccine. We're having a hard time getting vaccine supply right now, so I'm wondering what would be some advice for that.
Maybe I'll try to answer that. So are you specifically talking about the vaccines or nirsevimab, the monoclonal antibody?
Specifically the vaccines. We haven't been able to locate those resources.
Okay, that's interesting. I have not heard that previously. Our biggest challenge has been more with nirsevimab, which is being allocated by the CDC. I think the RSV vaccine itself is in the marketplace. It's not been identified as having any shortage. I don't know who your specific distributors might be when you purchase vaccines, but I guess I would ask, based on who you might have contracts with, that you check different suppliers, because there is plenty of supply of the vaccine out there. So it may just be a question of finding the right vendor who has it to send to you.
Okay, that's great to know. Yeah, I think we've only tried one vendor that we usually work with, so
Okay.
definitely try that strategy. Thank you.
I think that would be my suggestion. Yeah.
Okay, thank you.
Dr. Pisani, I have another question actually about the RSV vaccine.
Sure.
So for the adults who may end up going into a pharmacy, we are hearing anecdotally, I have heard it also through my Rotary Club, that the shared clinical decision-making is a bit of a barrier in a way that in some states, the pharmacist seems to feel empowered to do that shared decision-making, but in other states, they are being told to go to their provider. I don't know if they're asking them to get a script, but they're asking them to go to their provider to have that conversation. How does it work in a state like Connecticut, for instance?
So really, this isn't a state by state decision. It really is a provider by provider decision. And the reason I say that is, the ACIP who makes these recommendations, I sit on the ACIP as a member of the Association and State and Territorial Health Officials. So I'm one, the health official for Connecticut. And so that's our professional society, and I'm not a voting member, but I heard all the testimony and conversations around the approval of this vaccine. And essentially what it comes down to is that because there are younger people in the 60+ age group who may benefit, but may not benefit as much as some 60+-year-olds who have a lot of comorbidities, and particularly in some of our disadvantaged communities, the goal was to make sure that vulnerable populations could have access to the vaccine because they have more comorbidities. Even if a very, very healthy 60-year-old certainly may benefit, but not at the same magnitude that somebody who has more comorbidities in that younger age group may benefit. And then in the older age group, there were some members of the ACIP that were concerned that there were never studies done to the full extent as maybe in a ambulatory outpatient population in the long-term care setting. And for long-term care residents, there was some question that was raised by some members of ACIP in terms of there hadn't been as much results in that population. So when that happens, a lot of times they end up with this shared decision-making model recommendation. And the challenge is exactly what you're talking about, the barriers that creates. And so really speaking, it's not a state-by-state decision. There are pharmacists that may feel comfortable saying that they can provide that kind of advice, unless there's something specifically within the scope of practice and law around the pharmacist in a given state that they are not able to talk about that kind of stuff, versus that a given provider can or cannot make that decision. So I don't know if that really answers your question, but I think I do fully recognize some of the barriers that are brought up by having this shared decision-making model. And I also recognize that because of Part B and Part D coverage of the vaccine, there are providers who may give advice but won't vaccinate in their office. And the pharmacist may have the vaccine but don't want to give the advice, which doesn't create for a lot of easy administration or uptake of it. So that, I think, is one of the challenges, and I think we'll continue to work through this in the years to come. I think if I were to give advice to anybody on the call or any providers on the call, certainly older patients with more comorbidities, I think there is significant data to say that this is a protective vaccine for that group. I think where there is some question is for the younger, older adults with not too many comorbidities. It's still protective, but the magnitude is not as much. And then for the oldest of our old, you know, we don't have as much studies. So it's, you know, we know that if we know it's been protective in other populations, but we don't have as much data in that population.
Thank you, Dr. Pisani. We do have a question in the chat for Elise. In creating a culture of vaccinations, any insights on how to encourage people to continue to receive care at their UIO rather than feeling deterred if they are vaccine hesitant and begin to feel overwhelmed by vaccine messaging?
That is an excellent question, and I feel like I could talk about it for a long time, but I think what I'd first like to acknowledge is that there are so many factors that go into a person feeling overwhelmed with all of the messaging, and it might be vaccines in general, or it might be just one vaccine. It depends on the person. So my advice is, first of all, we know that healthcare providers are still the most trusted source, or one of the most trusted sources for people's healthcare needs in general. So I think having trainings for our healthcare providers and their teams around meeting patients where they're at is really, really key into some of these communications. The one-on-one communications between providers and patients. I think the other thing to remember is that it's a vaccine recommendation can be a process. So there are some data that, and it might be in the adolescent platform now that I think about it, not the COVID-19 space, but that if a patient refuses a vaccine, within 6 months, if the healthcare provider continues to reach out and continues to meet the patient where they're at and continues to provide that strong recommendation, within about a 6-month time frame, that patient's no turns into a yes. So again, I apologize now that I start saying that out loud. I think again that's in the adolescent platform space, but and not necessarily the adult space. But I think some of those same concepts can be applied in this space.
Great, thank you so much. I don't see any other questions in the chat. So we could move forward with the presentation, but we will keep an eye out for anything that comes along the way. We do want to, again, invite you to share your feedback with us after this session. That way we could help improve our technical assistance to all of our UIOs. Next slide. And NCUIH has updated our Be a Good Relative COVID-19 graphics to include flu and RSV vaccines. So we do have the link as well to these new resources as well. Next slide. And we also wanted to mention NCUIH and the COVID-19 Vaccine Education and Equity Project are partnering to share information about COVID-19 vaccines. And we are asking our UIOs to join our efforts to build trust and confidence in authorized and approved COVID-19 vaccines. The You're Covered campaign is a great resource for learning more about how to get your vaccines and if they're still free. Children are covered free of cost through the Vaccines for Children or VFC program, and adults are covered free of cost through a combination of public and private programs. The Bridge Access Program, administered by the CDC, is a public-private partnership that started in the fall and provides COVID-19 vaccines free of cost to uninsured or underinsured adults. And for more information on fact sheets, posters, or social graphics, we'll drop that link in the chat as well. And we also wanted to mention some of our upcoming events. For save the date for this Community of Learning series, our third and final session will be on January 11th. And that will be focusing on mobile vaccine clinics with speakers from Denver Indian Health and Family Services and Native Health. And then we do have a few more events for November, and then there's several for December. So we do have the link to our NCUIH events to take a look at those and register for ones that are applicable to you. And we also have some funding opportunities listed as well. We do still have our application for the electronic case reporting award available for one UIO. So that's still going on a rolling basis. Next slide. And again, thank you so much to everybody who joined, and a big thank you to our speakers, Dr. Jitani, Amy, and Elise. We truly appreciate all of your amazing information that you provided, and we look forward to the next session. So thanks, everybody. I hope you have a great rest of your day.
Thank you for having us. Thank you, everyone.
Thank you.